The following podcast is part of a certified educational activity. Access the entire activity and complete the post test at peerview.com/PHH860. Downloadable slides and practice aids are also available.
Hello and welcome to this session entitled Harnessing the Immune System in the Treatment of Triple-Negative Breast Cancer to Maximize Benefits to Patients. My name is Heather MacArthur, and I'm a breast medical oncologist at the Samuel Ocean Cancer Center at Cedars-Sinai Medical Center in Los Angeles, California. And it is my sincere pleasure to welcome my esteemed colleagues, Dr. Hope Rugo from UCSF Helen Diller Family Comprehensive Cancer Center in San Francisco, California, and Professor Peter Schmidt from the Center for Experimental Cancer Medicine at Bart's Cancer Institute, St. Bartholomew's Hospital in London, England. Welcome. So here's today's agenda. We will first provide an overview of the state of the evidence on cancer immune therapy for triple-negative breast cancer. We will then review some practicalities of clinical integration of cancer immunotherapy into the triple-negative breast cancer treatment arsenal, and then conclude with some summaries and key takeaways. So first, I'd like to provide an overview of the state of evidence on cancer for immunotherapy for the treatment of triple-negative breast cancer. And the reason why there's so much excitement around the application of immune therapy for the treatment of cancer is that when we can successfully train the immune system to recognize cancer, we can develop long-term durable responses. Unfortunately, to date, immune therapy has conferred benefits for the minority of patients, and we need to create strategies so that it can be relevant for the majority of patients. And when we look at the cancer immunity cycle, we might get some insight as to what strategies we might adopt to better augment immune therapy for the treatment of cancer. So PD-1 and PD-L1 directed therapy really addresses the last phase of the cancer immunity cycle. So it's probable that we will need strategies that address other stages of the cycle together with cancer cell death or PD-1, PD-L1 blockade to make immune therapy relevant for most cancer patients. And chemotherapy represents one such partner. We know that although chemotherapy can be immune suppressant, the right agents in the right doses at the right time can actually induce T-cell infiltration into tumors. And many of the chemotherapeutic agents that we use routinely in breast cancer clinical practice can exert those effects. There were a number of phase 1 and 2 trials demonstrating the synergy between chemotherapy and immune therapy that ultimately led to the first randomized phase 3 study of checkpoint blockade in the form of PD-L1 blockade with atezolizumab together with nab-paclitaxel in metastatic or advanced inoperable triple-negative breast cancer. So that was the Impassion 130 study. Patients were randomized 1-to-1 to receive nab-paclitaxel with either atezolizumab or placebo. There were several stratifications, specifically prior taxane use, the presence or absence of liver metastasis, and PD-L1 status on immune cells by the Ventana SP142 assay. It's worth focusing for a moment on a few baseline characteristics of patients participating in this study. For example, PD-L1 positivity was present in approximately 40% of patients. And it's worth noting that approximately 60% of patients received prior neoadjuvant therapy or adjuvant therapy, indicating that approximately 40% of patients had de novo metastatic disease. Here's the primary progression-free survival analysis. There was a slight improvement in progression-free survival in the intention to treat population from 5.5 to 7.2 months. Slightly larger improvement in the PD-L1 positive subset from 5 months to 7.5 months. And in the first interim overall survival analysis, there was an increase in overall survival in the intention to treat population from 17.6 to 21.3 months. However, this was not statistically significant. And as such, an informal analysis for overall survival was conducted in the PD-L1 positive subset, with a reported improvement of 9.5 months in overall survival from 15.5 to 25 months with the administration of atezolizumab to the nab-paclitaxel backbone. And this is particularly notable given that historically The median survival of patients with newly diagnosed triple negative breast cancer was in the order of 18 to 24 months. So to observe a 9.5-month improvement in overall survival in this population was particularly encouraging. This overall survival data was updated at last year's ASCO meeting with a maintained improvement in overall survival of 7 months from 18 to 25 months. So last year, we saw an approval by the Food and Drug Administration for atezolizumab together with nab-paclitaxel for patients with unresectable, locally advanced or metastatic triple-negative breast cancer whose tumors express PD-L1, where PD-L1 stained tumor-infiltrating immune cells of any intensity covering greater than or equal to 1% of the tumor area as determined by an FDA-approved test. We also recently saw the results of the KEYNOTE-355 study. This was reported at the most recent ASCO meeting by Dr. Cortez. In this study, patients were randomized in the first-line setting 2-to-1 to receive chemotherapy with either pembrolizumab or placebo. Notably, chemotherapy administered was physician's choice chemotherapy with the options of paclitaxel, nab-paclitaxel, or gemcitabine carboplatin. So asking the question, is immune therapy relevant with various chemotherapy backbones? There were a number of primary endpoints: progression-free survival in the PD-L1 positive tumors and in the intention to treat population, as well as a co-primary endpoint of overall survival in those two subsets, the PD-L1 positive and the intention to treat population. It's worth noting that 75% of patients participating in this study were PD-L1 positive as determined by the combined positive score greater than or equal to 1, and approximately 40% with the combined positive score greater than or equal to 10. In this study, approximately 30% of patients had de novo metastatic disease. And here's the progression-free survival Kaplan-Meier curve that was presented for the intention to treat population. So an improvement in progression-free survival from 5.6 months to 7.5 months with the administration of pembrolizumab to chemotherapy. This improvement was magnified for the combined positive score greater than or equal to 10, 5.6 to 9.7 months, and the overall survival data from this study is highly anticipated. Whenever we see progress with specific strategies in the metastatic setting, we always want to move those into the curative intent setting to see if we can improve cure rates. And we have seen that with immune therapy. So recently we saw the results of the KEYNOTE-522 study. This was a study of neoadjuvant chemotherapy with either pembrolizumab or placebo for patients with newly diagnosed curable triple-negative breast cancer. In this case, the chemotherapy backbone was weekly paclitaxel together with carboplatin, followed by an anthracycline with cyclophosphamide prior to surgery, and then patients went on to receive adjuvant pembrolizumab or placebo, depending on the arm assignment. There were two co-primary endpoints: pathologic complete response rate and event-free survival. And we saw in this first report that the addition of pembrolizumab to the chemotherapy backbone conferred a 14% improvement in pathologic complete response, a benefit that was observed regardless of PD-L1 expression. So the absolute benefit in the PD-L1 positive subset was 14% and 18% in the PD-L1 negative, indicating that immune therapy, when administered earlier on in the course of the disease, could be relevant for both PD-L1 positive and PD-L1 negative tumors. And we saw a first hint that these strategies and these improvements in pathologic complete response could actually translate into long-term improvements in cure rates. With 15 approximately median months follow-up, we saw an estimate of the 18-month event-free survival with an absolute 6% improvement in event-free survival, 85% to 91%, again indicating that the administration of immune therapy in the early stage setting could confer improved cure rates for this high-risk population. We also recently saw a press report from the Impassioned 031 study. This was a neoadjuvant study evaluating the addition of atezolizumab versus placebo to another chemotherapy backbone, in this case, nab-paclitaxel for 12 weeks, followed by an anthracycline with cyclophosphamide before surgery. And again, atezolizumab versus monitoring in the adjuvant phase, depending on the study arm assignment. And 2 weeks ago, we saw this press release indicating that the phase 3 IMpassion031 study met its primary endpoint by demonstrating a statistically significant and clinically meaningful improvement in pathologic complete response for the treatment of patients with early triple-negative breast cancer, regardless of PD-L1 expression. So benefits similar to those seen in Keynote 522 with improvement of pathologic complete response for both the PD-L1 positive and PD-L1 negative populations. So the details from that study are highly anticipated. It's worth noting that there are a number of other ongoing efforts in the curative intent setting. The question of whether immune therapy with chemotherapy is effective at treating micrometastatic disease. So the IMpassion030 study is a global phase 3 study looking at paclitaxel followed by doxorubicin with cyclophosphamide plus plus atezolizumab versus not in the adjuvant setting. And the SWOG 1418 study is looking at pembrolizumab versus observation in the adjuvant setting for patients with residual disease after standard of care chemotherapy. Those results are also highly anticipated. And now I'd like to turn it over to Dr. Rugo, who will speak to the latest research into biomarkers and evidence that should inform PD-L1 testing in current practice.
Thanks so much, Heather. I appreciate me participating in this program and talking about this really exciting and important data. I'm going to talk about biomarkers and the information we have that informs PD-L1 testing in current practice, keeping in mind that currently the neoadjuvant data suggests that efficacy is seen with immunotherapy regardless of PD-L1 testing results, potentially because the immune system is more intact and the tumor hasn't downregulated as much of the ability of the host to respond. The host itself, of course, may have some different response to tumors in the early versus late stage setting. But what we've actually seen is that in patients with metastatic disease, PD-L1 expression appears to be very important. And when we look at matched tumor samples from early to late stage disease, we find not only that there is a decrease in tumor infiltrating lymphocytes, but also a decrease in PD-L1 expression. So the tumor is able to downregulate its appearance to the host, as well as the host having less intact immune system. So there have been a couple of exploratory biomarker analyses from IMpassion130 that you just heard about. And we evaluated the immune biology, BRCA1 and 2 mutation status, as well as whether or not different testing methods for PD-L1 were more or less effective in assessing the benefit from the addition of atezolizumab to nab-paclitaxel. This data actually was first presented by Leisha Emmons on behalf of the IMpassion investigators in San Antonio in 2018. And you can see here an example of a PD-L1 IHC assay using SP142 with PD-L1 on tumor cells and PD-L1 IHC on immune cells surrounding the tumor cells in the stroma. So this shows you that PD-L1 is expressed primarily on tumor-infiltrating lymphocytes in patients with metastatic triple-negative breast cancer, keeping in mind that this data came from a mix of tumor samples obtained from the early and late-stage setting. Of course, in this situation, tumor was obtained even from archival samples as well, as you'll see in just a moment. So if you look at the data here, on the right-hand side of the slide, you can see that PD-L1 was positive in immune cells in 41% of the tumor samples and tumor cells in 9%. What you can see is just 2% of the tumor samples had PD-L1 that was positive only in the tumor cells and not in the immune cells. So it does appear that if you look at the immune cells, you gather most of the PD-L1 data using the SP142 antibody by immunohistochemistry. This shows you this as well in another way in a pie diagram with PD-L1 tumor cells representing 9% of the 100% of positivity, which really means that you could use immune cells as your primary determinant. The other thing that's been of interest based on our experience in HER2 testing is whether or not it matters how strong the tumor is in terms of its positivity by immune cells. And if you look in the upper right-hand side of the upper left-hand side of this slide, you can see that of the patients who had the 41% who were PD-L1 immune cell positive, that 14% were strongly positive and 27% were more weakly positive. Interestingly, with SP142, as you'll see, that doesn't seem to really make a difference. So any positivity was sufficient. As you know, and as you saw that in the previous part of this presentation, PD-L1 status on immune cells in the tumor stroma predicts the benefit in terms of progression-free survival for atezolizumab and nab-paclitaxel, shown here with a difference of 2.5 months. If you look at the patients whose tumors were PD-L1 immune cell negative, even keeping in mind that tiny number that might have positivity in the tumor cells, you can see that there was no benefit in progression-free survival. Similarly, the benefit in overall survival with an absolute difference here shown in the initial presentation of 9.5 months, but subsequently in the final evaluation of 7 months, shows that overall survival was significantly longer in patients receiving atezolizumab if their tumor had immune cells that were positive for PD-L1. And this was defined as 1% or greater, so it didn't have to be a high number. And there was no benefit in overall survival in patients who had PD-L1 immune cell negative tumors. Now, it's important, I think, as we think about our patients to keep in mind this, 18 to 19 month overall survival in patients who were more than a year from their adjuvant taxane or had de novo metastatic triple negative breast cancer, as we think about new directions for the future, because we are benefiting the 41% of patients who had PD-L1 IC positive disease, but there's a large number of patients who need new approaches. What about BRCA status? We know that a minority of our patients will have BRCA mutant disease, but when you look at metastatic triple negative breast cancer, and this is shown very nicely in the population of patients enrolled in Impassion 130, 15% of patients had mutations in BRCA1 or 2. If you look at BRCA1 and 2 in terms of predicting benefit from the addition of atezolizumab, benefit was seen only in patients who had PD-L1 IC positive disease. And in fact, having a germline mutation in BRCA1 or 2 was independent of having tumors that were PD-L1 immune cell positive, which is interesting data. And really, we didn't know this well before. And you can see here that 7% of patients who had BRCA1 germline mutations had PD-L1 IC positive disease. And here's the group of patients who were non-mutated who had PD-L1 IC disease. Patients who had BRCA1 mutant disease derived benefit in terms of progression-free and overall survival only if their tumors were also PD-L1 IC positive. And interestingly, when we looked at two different factors which have been prognostic in early stage triple negative breast cancer, patients who had high TILs, et cetera, or CD8 positive T cells that were high had benefit only if their tumors were PD-L1 IC positive. So PD-L1 really was the primary determinant of benefit of adding atezolizumab. This shows you the intensity information that I mentioned earlier, looking at how positive the tumor was. There was no benefit in patients who were IC0 for PD-L1 using SP142, but the benefit, as you can see in these little diamonds lined up here in the forest plot, were very similar in terms of progression-free survival and overall survival, regardless of whether a tumor was IC1 or IC2 or 3. So we're not really using intensity of staining. You can see wide differences here in overall survival, but this is simply numbers with a smaller number of patients with IC2 and 3. So it certainly does not indicate that we should be using intensity for testing. Now, one of the really interesting things that I think was a question for all of us when this data first came out was whether or not it mattered where you got your tumor from. Was it primary or metastatic tumor tissue, or did the organ that you biopsied make a difference? So if we just talk about the primary versus metastatic tumor tissue, you can see here primary means breast and metastatic is any other site. You can see that primary tissue was more likely to be PD-L1 positive versus metastatic tumor tissue. But interestingly, there was a median of only 60 days from the tumor acquisition of the tumor sample until randomization, suggesting that many of the patients whose providers submitted primary tumor tissue to assess PD-L1 status actually had de novo metastatic disease. So that was at the time of their presentation with metastatic disease. In And also importantly, it didn't matter where you got your tumor from. If it was PD-L1 positive, you still had a benefit in terms of progression-free and overall survival. So this is primary on the top and metastatic tumor tissue. It doesn't matter where you get your tumor from. What's important is to get some tumor to test. And then by anatomic location is also important. You can see only 5% of the tumor samples were from the liver, a little bit less tumor tissue potentially, and people used primary tumor in that setting maybe, but only 13% were PD-L1 positive in this small number of samples. So this has been seen in other diseases where PD-L1 positivity is less, and you see less TILs in liver, and this is represented in the Impassion 130 population as well. Otherwise, it's interesting that the levels in breast, lymph node, and lung were also very similarly high. Again, small numbers, but encouraging and seen with other tumor types as well. And correlates to some degree with responses seen in these organs as well. We wanted to compare the different assays that have been used to test PD-L1 status. So we looked at SP142, the assay used in Impassion 130, 22C3, which is a clinical combination score called CPS, and the antibody is 22C3, and then SP263. 22C3, the CPS score is the PD-L1 status on tumor cells, lymphocytes, and macrophages divided by the number of tumor cells. Again, it's a different antibody. And SP263 is scored similarly to SP142, immune cells of 1% or greater. What you can see is it's much more common to have positive disease using 22C3 or SP263 than it is from SP142. We use the biomarker evaluable population, which is 68% of patients in the total trial, and 46% were positive, but the clinical characteristics were similar. If we look at overlap, it's fascinating to see that positivity by 22C3 or SP263 isn't captured within the SP142 positive population. But there are additional, about 30 to 36% of tumors that will be positive only for these other antibodies. So what does that mean in terms of response to checkpoint inhibitor therapy? And this is shown very nicely here. Again, this is a subset of patients enrolled in Impassion 130, so it's hypothesis generating information. And what you can see is, again, very high percentage positivity for 22C3 using the CPS score with 1 or greater as a score, and 263 with 1% or greater. The benefit is primarily in patients who are positive for SP142 with less benefit. So 4.2-month difference in PFS versus a little more than 2 months for the other antibodies. The same is true for overall survival, with the widest difference seen 9 months for the SP142 and much smaller differences in using the other two antibodies. What about if we use all the antibodies and look at double positive versus single positive? Again, SP142 positivity appears to be key here, where the benefits are seen in patients who are SP142 positive and 22C3 positive, but not in patients who are negative and positive for 22C3. And of course, we see no benefit in the double negatives as shown here. In fact, by looking at the double positive, it almost seems like you could amplify the benefit. Although again, this is looking at a subset population. The same is true using the 263 antibody, a less commonly used antibody shown here, where the benefit is all in the double positives. So now we recently saw data, as nicely shown in the previous presentation, about using the CPS score, using this other antibody, 22C3. And indeed, about 75% of the tumors had a score of 1 or greater. However, the benefit was seen primarily in patients who had a high CPS score. Here you can see the CPS of 1 or greater, 10 is 38%, which is very similar to the 41% we saw in Impassion 130. But one thing we don't know is whether or not these populations completely overlap. And in a sub-analysis that we did in Impassion 130, it does look like there is some overlap, but it's not complete in terms of looking at this stronger CPS score and SP142 score of 1% or greater. But indeed, very exciting to see that there was a benefit in this population of patients in terms of progression-free survival with the addition of pembrolizumab. If we look at the two different PD-L1 CPS subgroups, you can see here that here's a CPS score of 1 and 10, and all the benefit appears to be in the patients who have CPS positivity, but there's a greater benefit in CPS of 10 or greater, and here is the score of 20 or greater listed here. And then if you look at different prognostic factors in terms of looking at benefit in patients, disease-free interval, number of metastatic sites, prior same class of chemotherapy, you see that these boxes all line up to the left of one, which is encouraging. One thing that's interesting, and again, it's a small population, so it's hard to know, and it may just be that this picked out the worst group of patients, but it seems like there was more benefit with the taxane partner than gem-carbo seen here, but the confidence intervals are broad and it's hard to know. Again, patients who received gemcitabine probably relapsed early after their adjuvant or neoadjuvant therapy. So again, the benefit may have been less in that group of patients. And it's similar if you look at the different CPS scoring systems. So now I'm going to turn over the podium to Professor Peter Schmidt, who's going to talk about mechanistic underpinnings for the development of immune-related adverse events, looking at data from the clinical trials, as well as really important factors in management.
Thank you, Hope. It sounds, when you first hear the title, it sounds a little bit boring compared to the exciting data Heather and Hope were just able to share. But I think clinically, this is really important. Immune therapy is fairly new for the breast community, in contrast to other areas in cancer treatment. And there are a lot of things we've learned about immune therapy, about what causes side effects and how we can manage this. So this will become increasingly relevant with immune therapy moving into the early disease setting, as Heather shared with you, but also with us using increasingly triplet combinations that have a higher risk of causing side effects. If we compare in a very simplistic way chemotherapy and immune therapy, we know with chemotherapy, practically all patients have some sort of side effects, whereas with immune therapy, the majority of patients generally don't have side effects. If we look at the type of side effects we see, with chemotherapy, if we mention 3, 4, or 5 side effects, we capture the majority of the adverse events, whereas we all get the impression with immune therapy, side effects are much more variable. If you look at the affected organs and the symptoms associated again with chemotherapy, very well described, whereas immune therapy, in theory, anything is possible. And similarly with the time course, where patients who develop side effects after chemotherapy, it's very predictable. We usually know on day 1 or 2, this will happen, on day 5 to 8, this will happen. With immune therapy, side effects can happen at any point in time, and sometimes even after the end of treatment. So there was initially, when we started giving immune therapy, a feeling that chemotherapy side effects are very predictable. On the other hand, immune therapy side effects are a little bit less predictable, and therefore it's something we need to get our head around how we best prevent or manage them. Now, one of the things that's really important is when we modulate the immune system, we check for this balance from what you see on the right side with immune tolerance to what we hopefully don't want to see, an unchecked immune response. And that can lead to possible side effects. And these are what we call immune-related adverse events or side effects. They're typically affecting a number of organs, and I will go into this in more detail, but they can also have general side effects such as fatigue, fever, chills, or infusion reactions. Now, one of the things that's really important to remember is when we give immune therapy, we essentially have an antidote to most of the side effects. We can give corticosteroids, and corticosteroids shift the balance back to the right, back to immune tolerance, and can deal with most of the side effects very effectively and very quickly. Now, next, if you look at how do those side effects occur, and I think there are 2 or 3 things, in my opinion, that are interesting to share. So if you look at the time curve of what happens in the body with immune therapy, after we gave immune therapy, there's an increase in polyclonal tumor-specific T cells, immune cells. So these are the cells we want to go up. These are the cells that are ultimately tackling the cancer. But at the same time, what we sometimes see happening is that there's what I would call an autoreactive clone, and these can be T cells, but it can also be B cells. And these cells are tackling or cross-reacting with other structures in the body, and therefore autoimmune. A third observation we sometimes see is that very early on in the treatment, and this is particularly relevant with triplet combinations, we see that the innate immune system can lead to an inflammatory reaction. So this is just an inflammatory reaction that's not triggered by a reactive T or B cell clone. And I always describe this patient's a short wave that comes in and goes away very quickly and is not going to come back. Why is this relevant? Well, it's ultimately relevant because it determines how we manage side effects. If you look at the very brief autoinflammatory wave, that will go away relatively spontaneously. On the other hand, if you deal with an autoreactive T or B cell clone, we need to give treatments, steroids in particular, immune suppressive treatment that try to get rid of this cell clone. And if you try to get rid of a particular cell clone, you need to give that treatment long enough. That's one of the reasons why we always recommend, if you have significant side effects, give steroids for at least 4 weeks with a long taper. If you give the steroids not long enough, these autoreactive T or B cells will just pop up again and the side effects will come back. Let's talk a little bit about the organs that can be affected. And essentially, just running through this, practically all parts of the body can be affected, predominantly the endocrine system, which is interesting and very specific to immune therapy, but also the respiratory system, in particular with pneumonitis, gastrointestinal system with, for example, colitis. We have the skin with rash, which is one of the more common side effects. Hepatitis can be seen, and then in relatively rare side effects, renal effects, arthritis, dermatomyositis, any form of reactions we can see in the form of autoimmune disorders. Neurological side effects are rare. Eye side effects are rare. Hematological side effects and cardiovascular side effects are rare, but can, in theory, all occur. So what do we see in breast cancer trials? What is common? If I share some of the phase 3 data with you, and Heather spoke about the trials already. In the left top corner, you see Keynote 119, second, third line single agent trial. You see in green immune therapy, and in this pinkish color chemotherapy. And as you can see, if you compare chemotherapy alone with immune therapy, the acute, the most common side effects are much more prevalent with chemotherapy. If you look at the top right side, these are data from the Keynote 522 trial, neoadjuvant chemotherapy and immune therapy given together versus chemotherapy. Again, same color coding is green is just chemotherapy, is green is chemotherapy and immune therapy, and pink is placebo and chemotherapy. And as you can see, the side effects here during the chemotherapy phase are very clearly dominated by chemotherapy. Immune therapy adds very little to it. If you look at the left bottom corner of this slide, we see the side effects after surgery, when chemotherapy is stopped and patients receive immune therapy alone or placebo. And again, you see very low incidence of significant side effects, and these are relatively comparable between those arms. But if you look specifically at the so-called immune-related side effects, and on the left side is combined data from different phase 3 studies, you can see there are some side effects that are a little bit more common. In yellow, we can see all the endocrine side effects, and these are the most common one. The most commonly observed within the endocrine side effects are changes of the thyroid function in the form of underfunction of the thyroid gland, or hyperthyroid, overfunction of the thyroid gland, which usually then leads to hypothyroid. Other endocrine side effects, for example, adrenal insufficiency, relatively rare, diabetes rare, but can be observed in a small group of patients. What I often say is there are 5 side effects we all need to know, 5 complexes of side effects if we give immune therapy. The first one is endocrine side effects, particularly with thyroid. The other 4 are rash, as you can see on this slide, pneumonitis, inflammation of the lung, colitis, inflammation of the large bowel, and hepatitis. Now, what's interesting, if you look at the right side of the slide, these are immune-mediated side effects that were significant enough that the clinicians felt they need to give steroids to treat them. And with the exception of rash, we see most of the side effects are in the 1% range. Pneumonitis about 2%, but then all the other side effects in the 1% range. So you can see, yes, there is a potential for substantial side effects, but they tend to be relatively rare and relatively rarely need therapeutic intervention. What about the timing of those side effects? And when we again first developed immune therapy, we thought there's a particular pattern when those side effects occur: rash a little bit earlier, then diarrhea, endocrine side effects later, pneumonitis relatively late. And that's something you find in the textbooks. And that's something I would like you to forget immediately. The timing of immune side effects can be highly variable, especially when we use novel combinations. Immune-related side effects can occur at any point in time during the treatment, but even months after the treatment, and you just need to be aware of that. How do we manage side effects? If you look at grade 1 on the left to grade 4, whenever possible, we should give symptomatic therapy for all of those side effects. With grade 1 side effects, we normally continue with a checkpoint inhibitor. With grade 2, for certain selected side effects, we pause. And certainly with grade 3 side effects, we pause or discontinue the checkpoint inhibitors. In terms of steroids, for many of the grade 2 side effects, we would consider oral steroids. When it gets to grade 3, we usually consider intravenous steroids, depending a bit on the type of the side effects. And if you do give steroids, give them adequately dosed at 1 to 2 milligrams per kg body weight initially at least, and also consider a long enough treatment and a slow taper over 4 to 6 weeks for the reasons I mentioned before. We often hear in the textbooks refer and involve specialists, and I think that is correct. But my experience is we need to be in charge of this as oncologists and should be able to deal with most of the side effects. And we generally involve specialists when we need to go beyond steroids and use stronger immune suppression, which tends to be relatively rare. Most of the side effects can be managed in the outpatient setting, and it's very rare that we admit patients for this. Now, if you look at the management of side effects in total, it's a multidisciplinary event, and from gastroenterologist to ophthalmologist, rheumatologist, endocrinologist, hepatologist, everyone plays a role in there. But what I would like you to take away is that the central role needs to be taken up by the oncologist. We need to drive the diagnostics, but also in parallel already start with immune suppressive therapy and not wait, for example, for 3 days until the chest physician may have done a bronchoscopy, or for a week until the gastroenterologist has done a form of endoscopy. So in summary, the management of immune-related adverse events is immune-related adverse events are highly variable in terms of the affected system, in terms of the combination of symptoms, and also in the timing. And what I would always say is anything can potentially be immune-mediated. However, if you count to 5 and look at endocrinopathies, rash, pneumonitis, colitis, and hepatitis, those 5 groups of events account for 90 to 95% of the observed immune-related adverse events. But of course, you need to be aware of rare and possibly serious other events. Early recognition and treatment is critical. We as oncologists should lead the immune-related adverse event management, but of course, consultation with subspecialty services is required and recommended in case these are not straightforward. Steroids are highly effective, from all what we know, don't affect the efficacy of the checkpoint inhibitor, and that's probably because some of that activity is driven polyclonal rather than monoclonal. So my suggestion would always be use the steroids rather once too often than not often enough. If you do give them long enough for 4 to 6 weeks in order to get on top of those side effects.
Thank you, Dr. Schmidt and Dr. Rugo, for those excellent presentations. They're really so clinically applicable and pragmatic. And I'd now like to pause for a moment because we have a number of excellent questions rolling in from our audience. And if you don't mind, I'd like to take a minute to address some of those questions. So the first one is as follows. Why does PD-L1 status not have predictive value in the early stage setting? Does this mean that immune therapy should be considered for all patients once approved? Or which factors should be considered in determining the candidacy of patients? Dr. Schmidt, what are your thoughts?
Yeah, it's a great question. And I think we're only at the beginning of being able to answer this question. So as we're all aware, there are 2 endpoints for the early trials. One is path-CR, and the second endpoint is recurrences of event-free survival. At the moment, we can only comment on the correlation of the PD-L1 status with path-CR with the initial response. We don't know whether the same will be seen when we look at long-term recurrences. But what we clearly see is there's no difference in the absolute benefit whether patients are PD-L1 positive or negative, although in general patients who are PD-L1 positive and have more immune cells tend to respond better to chemotherapy, and immune therapy still adds something on top of this. Now, why is that? I think one of the reasons, in my opinion, is that the tumors are there's a higher plasticity, it's more dynamics in the process. In metastatic setting, the tumors are no longer plastic, no longer dynamic. They're often, the immune system is exhausted, and you either have immune cells in there or you don't. In the neoadjuvant setting, in the early setting, we see that immune cells can rush into the cancer, that within 2 or 3 weeks from starting treatment with chemotherapy, we see an influx and an increase in immune cells, CD8 positive cells, and therefore also PD-L1 positive cells. So I think the immune system in an early disease setting is dynamic, is plastic, and therefore a PD-L1 negative tumor prior to the treatment may be PD-L1 positive 3 weeks later.
Thank you, Dr. Schmidt. And this question that just came in, Dr. Rugo, is for you. It really leverages on your terrific presentation about PD-L1 testing. So this question asks, for PD-L1 testing, should we send the primary tumor or the metastasis? And if we send a metastasis, is there a preferred site? Is liver not a preferred site? What are your thoughts?
It's a great question because we are, I think, always trying to decide what to biopsy and when, what kind of, risk for the patient of complications and discomfort, of course, every time we biopsy. And sometimes sites that we biopsy, we don't actually get enough tumor tissue to do immunohistochemistry. And we're trying to balance sending other tests, are we rechecking HER2 or are we getting NGS, et cetera. So I think the key message really is that the tumor sample that you have that's the closest to the time that you're treating the patient is the most appropriate tumor sample to send. And we don't know that it would be better to send one organ or another. If you have a primary tumor sample available from breast, a patient has de novo metastatic disease, or you have recurrence in the breast at the time of metastases, that's a very appropriate site to send, and it's safer for the patient. Same is true of nodes, soft tissue, et cetera. But it's not bad to send liver, it's just less positive. We don't actually know if there's discordance between different sites at the same time in patients because we haven't been able to biopsy multiple sites in these patients to understand that. And it's interesting, the primary tumors being PD-L1 positive did predict a benefit at the time of metastatic disease. But clearly this is a different situation than in the neoadjuvant setting when patients don't have metastatic disease as yet. And as Peter pointed out, I think the sort of enhancement of expression of PD-L1 by chemotherapy is something that we also don't understand well. However, the majority of tumors were positive for PD-L1 in the neoadjuvant trial using 22C3 as the antibody in the CPS score. So it suggests that, it's really hard for us to understand, but when you have less genomic chaos, untreated cancers, and the host immune system is intact, PD-L1 expression, as Peter elegantly explained, doesn't seem to make a difference. But in the metastatic setting, we really do need to know this in order to understand which patients will benefit the most from immunotherapy. But whatever tumor you have, go with it.
That's very helpful. Thank you, Dr. Rugo. And thank you to our audience for submitting a number of really excellent pragmatic questions that can be applied in clinical practice. Now I'd like to shift gears a little bit and talk about toxicity and review some cases that specifically address real-world toxicity issues. And I'd like to start with you, Dr. Schmidt. I think you had an interesting case of a 32-year-old woman that you could present, if you don't mind.
Yes, thank you, Heather. I think with the immune therapy treatment, we see a lot of things that are slightly different to how we would have treated before we had immune therapy. So this is a lady out of our practice, one of the first immune therapy patients treated initially. So she had early breast cancer and then recurred a year and a half later with small volume liver and lymph node metastasis. And liver biopsy confirms the metastatic triple-negative breast cancer. But the question really at that time is, what would you do? Would you give chemotherapy? Would you, if you're not in the US, give chemotherapy, for example, bevacizumab? Would you give chemotherapy, immune therapy, or would you do further tests? And obviously, based on what we heard from both Heather and Hope, it's clear we do need to do further tests. Now, we need to test for PD-L1. And if you do test for PD-L1, which part of the tumor do we biopsy? And I think until about 3 weeks ago, I would have said very clearly, if you test for PD-L1, we need to use the SP142 assay, as Hope shared with us, because that is the assay that's linked with benefit of atezolizumab, the only licensed drug in this setting. On the other hand, we have just learned from ASCO 2020 that in patients who receive 355 chemotherapy and pembrolizumab, we can also use the 22C3 assay as long as you have a 10% cutoff. That gives a similar group of about 40% who are positive and also defines the benefit. Interesting question is, how much do they overlap? And what we see is there's probably only about 75% overlap between those tests. In other words, even if your patient is negative for PD-L1 with SP142, still worthwhile considering testing with the 22C3 assay, the CPS of 10, because those patients may still benefit. If you have the choice between liver met or primary tumor, very clearly we would choose the primary tumor, I personally, in this situation, because there's a higher chance of being positive. The patient came back as PD-L1 positive. What other tests would we do? BRCA test is relevant, but in this setting for us, we would prefer to give immune therapy first. So we treated the patient with nab-paclitaxel, an immune checkpoint inhibitor, and the patient responded initially really well. As you can see, a baseline at 6 months, good reduction of those lymph node metastases, and but then we see that some of the lesions start growing again at some point, and suddenly we see large lymph nodes coming up. And the question is really, what do we do in this situation? You have a patient who's well, liver metastases are responding in a complete response. Some of the lymph node metastases are responding, but suddenly one of the lymph nodes is starting to grow. That's always a difficult question. And one of the decisions is this progressive disease or not? We decided in this case to carry on with the treatment and carry on and observe or monitor the patient very closely. And as you can see from the CT scans, those lymph node metastases went away over time, and the patient continued to have an excellent benefit. Now, then more than a year later, roughly, the patient was still in a CRI in her liver. The lymph nodes in the chest were well controlled, but the patient suddenly has a lesion of about just over an inch in the lungs, nothing else in the lungs, but this lesion is clearly growing. What would you do? And the question for us is, should we stop the treatment, change to chemotherapy? Should we just wait? Do we give fancy new radiotherapy? Do we do surgery? And this patient, the lesion was so well positioned that we could wedge it out. It was clearly another breast lesion, and it was fully removed. And the patient, almost a year on now, is still in a complete response. So the reason why I chose this case is for two characteristics we observe. One is we sometimes see disease progression in one site, and that can sometimes be, especially when lymph nodes are involved, pseudoprogression. If the patient is well and we're not with a rapidly active disease, it is worthwhile continuing the treatment for a while to see, is this really a progressive disease or is it just one side? The second reason is we're increasingly incorporating local treatment in some of those patients, especially if they have several metastases, but only one area is growing. It is worthwhile looking at these patients in a multidisciplinary way, doing radiotherapy or other local forms of treatment to control the disease, which often gives patients longer-term benefit.
So Dr. Schmidt, thank you for that excellent case. This is actually a question that comes up a lot, the issue around pseudoprogression and whether one should continue on the current course of treatment or change therapies because of true progression. How common do you think this occurs, this pseudoprogression?
So pseudoprogression is probably less common than we think. I would say it's possibly around 5%. However, where it comes down to how well trained your radiologist is. We often use the term lymph nodes hover around a bit. We see sometimes lymph nodes get a little bit bigger or smaller. And if you exclude those cases, then pseudoprogression is relatively rare. But what we've learned is when it's, particularly when lymph nodes are involved and when it's not all sites of disease, they can sometimes go up by a few millimeters and go down by a few millimeters, and that can happen very quickly. So it's not very common. It's much more common that if the cancer is growing, this is true progression than pseudoprogression. But it's important to be aware of both possibilities. And what I would always say is look at the overall picture. If it's one side out of many, it's more likely to be pseudoprogression. If it's lymph nodes compared to other sites, it may also be pseudoprogression. But it is something where imaging only gives us some element of information. We need to get a clinical feel for that.
And if there's a mixed response or you're considering pseudoprogression, does that impact the frequency with which you're doing imaging studies? In other words, do you repeat imaging earlier than you would do in routine practice for those who are clearly responding?
Yeah, it's an excellent question. So if you are not sure whether a patient is still responding, you don't want to send the patient away for 3 months and do the next scan then. So we tend to bring the next tumor assessment forward and do this sometimes as soon as 4 weeks afterwards, or then it depends a bit on the dynamic of the process, whether you do it after 4 or 6 or 8 weeks. But I wouldn't wait too long for a repeat assessment.
Thank you, Dr. Schmidt, for that excellent case. Dr. Rugo, any comments on Dr. Schmidt's case?
I think this is actually a really good example of patients who can be treated with some creative approach. So even when there are small incremental changes in disease, particularly soft tissue, and patients are asymptomatic, I think we need to be cautious about jumping to changing treatment, keeping in mind our ultimate goal of therapy to help patients live as long as possible with the best quality of life. And these small changes can be watched, although as Peter pointed out, you might want to watch them a little bit more closely depending on what's going on with the patient and the pace of their disease. But also, I think that the other areas, if a patient has a single site that's growing, say a supraclavicular node, or has a tumor in breast, you can manage that locally and continue therapy on immunotherapy. I know that Heather, you yourself are investigating the role of radiation in this area, and although we don't have definitive data yet in terms of enhancing the host immune response with radiation therapy or exposing neoantigens, I think that it's definitely something we've incorporated. I have one young woman who's been who was on, interestingly, on Impassion 130 and then progressed, but went on compassionate use immunotherapy, and because she developed a supraclavicular node that was radiated. She had one other nodal area radiated and stayed on single agent immunotherapy for over 4 years, and has just progressed and gone on in the same radiated site, and so has gone on oral chemotherapy. But she now thinks of this as a chronic disease, and it's a completely different situation, of course, in terms of the biology of her disease, than people whose cancers are rapidly progressing in liver or lung, and you just don't have that ability. But I think it's important to keep in mind that the diseases are really different, and we can approach this quite creatively.
Thank you for that. Now, I believe that you have a case that highlights immune-related adverse event toxicity issues. Would you mind sharing that case with us?
Absolutely. This is actually a really interesting woman who initially presented in 2005 at 55 years of age with a node-positive, hormone receptor-positive invasive cancer, and was treated with ACT and anastrozole for 5 years. 5 years after finishing her endocrine therapy and 10 years after diagnosis, she was discovered to have metastatic disease to bone, nodes, and lung. A biopsy showed, and it was a very small biopsy. This was done in an outside hospital. Showed that she had ER-positive HER2 2+ disease, and her FISH was not amplified. She was treated then with letrozole and palbociclib for almost 2 years, and then fulvestrant with rapid progression in liver and a little response to capecitabine. really fascinating case because then we biopsied her liver. I said, look, we've never actually tested your tumor, so let's see what we find here. And her biopsy of her liver showed that her tumor was still hormone receptor positive, but HER2 2+ with FISH amplification, copy number of 9.4 and a ratio of 3.1. So very interesting. And I think it sort of exemplifies how important it is to actually retest at some point tumor sample because something can be missed. She then was treated based on the Cleopatra data with paclitaxel, trastuzumab, and pertuzumab, given the survival advantage from this triplet type therapy with a taxane, followed by fulvestrant, and then continued double antibody therapy. And she stayed on antibody plus fulvestrant for about a year and presented with some progression in lung as well as extensive these cystic type brain metastases, which are quite unusual. She was treated with whole brain radiation therapy, and then for a small site of progression in 2019 received Gamma Knife and is completely stable now. She started on TDM1 and had a response followed by progression in lung. So at that point, I was thinking, okay, we didn't have the approval of our current two newer agents, but we did have a clinical trial through our Translational Breast Cancer Research Consortium that randomized to different combinations, and she was randomized to vinorelbine, trastuzumab, and a PD-1 inhibitor, and had an excellent response. And interestingly, since that time, her brain also has been completely stable and has been on therapy now for almost a year. However, she saw me in clinic in December of 2019, and she said, she was just feeling weaker. And of course, we thought that, a little dizzy, weak, a little nauseated. And we thought it was progression in brain, and she had a brain MRI, which looked great. So I then really, I think about 5 days later, she at home had an episode of, a couple of episodes of intermittent left arm weakness and then expressive aphasia. So her husband brought her to a local emergency room where she was admitted for hypotension, hyponatremia, and then continued nausea and dizziness. So, they tuned her up and gave her saline, and her sodium came up a little bit to 130. And 2 days later, the hospitalist called me and said, she's still really nauseated and dizzy and can't walk much. And I said, oh, could you check a cortisol possibly? And her cortisol was less than 1. And then, of course, to rule out hypophysitis or secondary adrenal insufficiency, we checked an ACTH, which was also unmeasurable at less than 1. Of course, she just had an MRI of the brain as well that didn't show anything wrong in her brain that would have been causing this. So we diagnosed her with checkpoint inhibitor secondary adrenal insufficiency. She was treated with hydrocortisone that day. And the day the results came back, and within less than 12 hours, her symptoms had completely resolved. She was discharged the next day. And actually, a funny story about how we educate our patients. She had been given just a 2-week supply of medication by the outside hospital. And, I was calling her to talk about the diagnosis and when she would be coming in for her chemotherapy. And she said, oh, my drugs run out tomorrow. Should I continue these medications? Or, I thought, she thought it was just a 2-week course and she would stop. And so I said, no, this is lifelong medication. And we refilled it and got her a medical alert bracelet. And she continues on that therapy now. She's been on now, this is her 8th month since being diagnosed with adrenal insufficiency. She's continued her study therapy without holding it, in contrast to some of the other immune toxicities where we actually need to hold or discontinue drug, as Peter nicely outlined. If you have pneumonitis, colitis, hepatitis, et cetera, you really do need to hold the checkpoint inhibitor unless it's very low grade. But for adrenal insufficiency, not only do we not like hypothyroidism or thyroiditis, not only do we not treat with steroids, although perhaps we should be high-dose steroids to try and eliminate the inflammation, but we also don't hold the drug, and patients are able to stay on and continue to benefit. So here she is 8 months out doing fabulously, wishing that she could travel back to her favorite location in England, but unable to because of our pandemic. But her disease is beautifully controlled, and she's doing well on her hydrocortisone replacement.
What a great case. And it highlights so many issues for me, including the importance of vigilance for patients who are receiving immune therapy and the importance of early detection. And it's worth reminding our audience at this point that immune-related adverse events can also be delayed and can occur even a year after last exposure to therapy. So this is particularly important for our patients who are being treated in the curative intent setting, who present even a year after they've last received immune therapy, that we still need to be vigilant. And I think that's a great segue into the patient caregiver education and engagement discussion and care decisions. It's increasingly important. Considering the patient and caregiver perspectives is of increasing importance in breast cancer. Particularly, there needs to be more individualized approaches to treatment selection and planning. Immune-related adverse event detection and early diagnosis are dependent on patients and caregivers recognizing and reporting potential symptoms, so education is key. The need for shared decision-making is paramount, a process of two-way communication during which clinicians and patients work together to make treatment and other care-related decisions. And patient and caregiver education and support is critically important. There are a number of organizations, including Susan G. Komen, Breast Cancer Alliance, and Triple Negative Breast Cancer Foundation, and so many others who have really terrific high-quality resources and support available for patients with breast cancer and their caregivers. Now I'd like to close by looking at some future directions for treatment of triple negative breast cancer with immune therapy. There is considerable interest in combining immune therapy with other chemotherapy agents. As Dr. Schmidt pointed out, we recently saw the data from KEYNOTE-355 looking at various chemotherapy backbones. And it's worth noting that the ENHANCE study looked at eribulin as chemotherapy backbone in combination with pembrolizumab, with some encouraging encouraging benefits seen, particularly earlier on in the course of disease. There's a considerable interest in AKT inhibitors with taxanes have been shown in phase 2 study to improve overall survival in both the LOTUS and PAC study, and are now being explored in combination with immune therapy based on encouraging results. There's considerable interest in looking at PARP inhibitors. The Mediated study, for example, looked at olaparib in combination with durvalumab with encouraging results. This is the KeyLink study looking at olaparib with pembrolizumab versus carboplatin and gemcitabine with pembrolizumab in the metastatic setting. And based on evolving data in both the ovarian and breast cancer setting, there are studies ongoing looking at olaparib combinations as maintenance therapy. So in this study, the DORA study, which is ongoing, patients with stable disease or response after a platinum-based agent are randomized to receive olaparib alone versus olaparib with durvalumab. Our group has been considerably interested in local regional strategies, including radiation, together with immune therapy, and have seen a pathologic complete response rate greater than 70% when pembrolizumab is combined with radiation before standard of care chemotherapy, and randomized phase 2 studies are planned. We've also been interested in cryoablation immune therapy studies based on the seminal work by Nobel Prize winner, Dr. James Allison. I think we can all agree that this is a fast-moving field with a lot of efforts, and we will not expeditiously move these efforts forward unless we collaborate. And I'd just like to point out that there are many different organizations that are supporting research and collaborations among industry, academia, and other key stakeholders. Some of those listed here: Breast Cancer Research Foundation, Susan G. Komen, and so many others. And examples of those types of efforts are outlined here. One is the Tribute study, which is supported by Parker Institute and is exploring the potential biomarkers to predict response to nab-paclitaxel with atezolizumab in the first-line metastatic setting. There are collaborations looking at very promising vaccines, and of course, looking at efforts outside of the triple negative setting. Dr. Rugo mentioned one in her case, but looking at how we might apply immune therapy for not just triple negative disease, but beyond. And I think it's a very exciting time, and we will all need to work together if we are to move this field forward. At this time, I would like to thank my colleagues, Dr. Peter Schmidt and Dr. Hope Rugo, for participating in today's discussion. I thought it was excellent, and I would like to thank those of you at home and at work for joining us today, and I thank you for submitting your excellent questions. And I hope that you found this presentation helpful. Thank you.
Thanks very much.
Thank you very much.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/PHH860. This activity is supported through educational grants from Bristol Myers Squibb, Eisai Incorporated, and Genentech. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.